Hi, everyone. Welcome to Perfusion Musings. This is the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Boutwell, the CEO here at Envello Medical.
And I'm Dan Rodenhaver. I'm the Chief Commercial Officer. Today, we're joined by Craig Beavers. Craig is a cardiovascular pharmacist who practices in a heart failure clinic in Kentucky, but he also serves as the Vice President of Operations and Cardiovascular Services Executive Leader at Baptist Health Paducah. He also is past chair of the ACC Cardiovascular Team Section. And most importantly to us, he graciously offers us time and serves on our scientific advisory board. Thanks for spending some time with us today, Craig.
No, thank you for including me. I'm excited to join you all in conversations and help continue to spread the good word about all things perfusion, or why it's important and why we need to care, and the role everybody plays in this management. So
Great.
Yeah, you've been a great teacher for us. I'm excited for you to hopefully help teach the rest of our audience about the importance of perfusion and the ways in which a cardiovascular pharmacist can help influence that. You've had a really sort of wide-ranging career as from a clinical pharmacist to a leader in cardiovascular services. And I'm interested in how you feel the role of pharmacists in cardiology has evolved over the years. Like what changes you witnessed as you've gone from this one stage of your career to another.
yeah, so I think the role of pharmacists in general, just as you think about in medicine, they've become more robust and more out front and more clinically focused, and being at the bedside and being a part of the team. No longer do you think about the pharmacist being, in the basement dispensing medications. Not that those they're very important functions and very meaningful, but I think as things have gotten more complex in managing patients, especially if you think about my domain and the groups that I've been trained to deal with and be a part of in the cardiovascular domain, there's so much complexity into these patients in terms of all the things that are occurring, and there's so much advancement, and everybody really has a niche and a role to play. So it's really a team-based sport. And so, having the skill and expertise and knowledge of how we're going to manage these patients from a pharmacotherapy or a pharmacologic standpoint, and understanding what that looks like in the construct of not just the distribution, but how things are going to be titrated, what they're going to interact, how we're going to manage these patients. It all becomes very important when you're looking at things that are overlapping. And even when you think about things that you don't inherently think of it being a pharmacy-driven process. So you take, percutaneous mechanical circulatory support, for example, or example that would be the Envello device that people think of. While that is a device and very important device to manage perfusion, there is essentially pharmacological components that go with that in terms of anticoagulation or purge solutions and things that really need to be optimized to prevent harm for the patient. So if you really think about it, I always joke and say, and of course can always be biased, and love for my physician colleagues and my nursing colleagues, they do amazing things, but I always say pharmacists are a part of everything in the care process, because medications are inherently a part of the care process. And so we get to see it from that angle and really contribute. So I think that's where the role, and people really appreciate and recognize that, especially if people have been trained in that pharmacists are key to helping optimize the patient outcomes and being a part of that process. And of course, when you talk about shock, you can talk about inotropes and other things. There's a whole breadth and layer of this in that process. So
Follow up, your comment on team was is sort of pervades all of the questions that I want to ask you there. You were also the first pharmacist at SCI, the Society for Cardiovascular Angiography Interventions. And like Dan said, you led the CV section routine at ACC. So it's great to hear your perspective. The team is what's really important. Digging into your question or your comment about ionotropes and how medicines are part of the delivery and the care of medicine. I'm curious about your perspective on guideline-directed medical therapy, which is a sophisticated and well-known technique for improving patient management, but understanding how to titrate your perfusion changes or how to assess the effect of the GDMT on perfusion was a sort of really critical component of how you actually do your direction of this medical therapy. How do you use how to adjust your...
Yeah, so I think, guideline-directed medical therapy inherently is very important, both in the acute phase and in that transition phase as you transition patients out of the acute phase or in the outpatient setting. And there's a couple of things that are layered to that. It's important that therapy be optimized for patients when they're in the outpatient setting. So that way we either prevent or limit the insult or injury when they are admitted from that standpoint. However, what happens if a patient does have a decompensation or is acutely in shock? We have to understand, for example, what things might be worth preserving or maintaining the patient on while they're in that shock phase. A great example of this is if you look across the literature over time, it used to be that the dogma was you would stop beta blockade, for example, when patients came with acute decompensated heart failure, because naturally it seems like, oh, we don't want to take away their heart rate response or their contractility response when they're acutely decompensated. However, we know that's a very important component to guideline-directed medical therapy. And we've had studies subsequently that have since shown that patients, as long as they're not in acutely terrible cardiogenic shock, we probably should try to preserve their beta blockers because the patients don't do worse and they actually do better upon that transition from that standpoint. So I think those are things we've learned and changed over time. But then, sometimes people want to provide inotropic support and still manage through with guideline-directed medical therapy because those components of therapy will help the patient progress out of those phases. And I think we're continually to learn with patients in shock what is obviously the best things from an acute management phase. And to your point, is that how do we use inotropes? How do we use them optimally? What does that perfusion look like? When do we need to maybe start them sooner versus later? When, have we been too late applying inotropic therapy, right? Or to prevent that piece from that standpoint? I think these are all questions we continue to seek to look for the answer. It's just, we know that these patients have a higher mortality and what are the things we can do? And sometimes we've learned the things that make sense and you would be like, oh, we probably shouldn't do this. We've learned maybe we need to change our thinking about this over time. So I think that's where, this is a field of opportunity and we have new things that are able to help a patient with cardiogenic shock. But again, getting back to the backbone of guideline-directed medical therapy, it's so important as maybe a cornerstone or a key is the questions are, how do we get people on GDMT and how do we maintain people on GDMT? And so that's what we're trying to figure out in the phases of the care of the patient and how to manage them. What are the things that we need to keep or optimize are important for the patient to be a part of as a part of that process in preserving their function.
Yeah, Craig, you talked about this as a sort of a team sport, and you see that at your own institution, but you also have a sort of a national presence, serving with ACC and a lot of the publications you put together. And do you feel like we're getting better? The specialty is getting better at standards of care, standards of practice across the country and across the globe, or do you still think there's challenges in one institution treating differently than another?
I think there is a more process of people getting kind of more congruent. I think to the point about teams, if teams get involved and engaged in that, you see some of that structure and playing of that come out in terms of what are roles and responsibilities of members of the team. I think when you think about shock, for example, when you think about a shock team and what their roles and who's managing it and what is the integration of that, and really what I think the bigger thing that helps with that is there is standardization that comes into that, but there's also increased communication that comes through that, so people are engaged to be a part of the process and treating the patient the best way that they're able to be treated. So I think we're seeing that evolution now. Obviously, in a space like shock, for example, we're getting better at understanding shock. We've understood a decent amount of shock as is, but there's still a lot to learn, right? And so providing that framework allows for the dissemination of that information to occur somewhat more quickly from that standpoint. Now, I'm not going to lie and say that everybody's doing everything standard across the world or the globe, and there are still gaps in therapeutic inertia that occurs. But I think people are more in tune to implementation science, decreasing that therapeutic inertia as quickly as possible and trying to get things that work and that we know that work integrated as quickly as possible. So
Are there some particular areas where you think that sort of standardization can improve? Things are still challenging?
no, I mean, in my mind, and I've seen this with our institution because we've done a standardized heart failure program and pathway and cardiogenic shock process. I think there is something to be said about having a standardized care pathway for these patients. We've seen it improve outcomes. You see less care variation. Patients are able, obviously every patient's slightly different, but if you have that structure, that framework in place that guides when things should be decided versus delaying, when the team should be engaged, what are the goals for the patient. I think all those things and having a little bit of accountability structure helps improve the patient outcomes. And so I think, you know, I can personally say with our system, doing that care standardization in a team-based fashion has really changed the trajectory of our patient populations. So,
And from your perspective and from your institution, what are the things you don't know? What are the things that you need to know? And
yeah,
is there places where industry can help? What's not being worked on yet?
I think, the things that we're trying to understand are, how do we identify these patients earlier? What do they look like? How can we intervene earlier? What does that look like? I think obviously if you look at the economics of it, how do we do this in a safe, effective, and efficient fashion? Because shock and the things that are associated with it can be expensive in terms of the care processes and management, but then also having a better insight into the patient and their hemodynamics and the ability to identify these patients may come up with more novel ways to manage these patients or changing the paradigm and what we need to do for them from that standpoint. So I think having more data and insight to understand, what could be the benefit or how do we manage these patients is key. And obviously ways that decrease risk, right? Because anytime you have to get data and it's inherently invasive, then that becomes problematic and there's concerns that are tied to this. But then obviously the other thing I would say, data that is meaningful for everybody on the team, going back to the team-based care process, right? Like data that the whole team can access and use and provide, implementation to the care process. And so I think that is uh, the key there is like, okay, it's data that's easy to get, but everybody can use and everybody has understanding of, and it can help drive care delivery. And that's where standardization can come from.
I think that's a great comment. I think you actually led me into, I think, maybe my last question, both about data and about the team. And this is sort of a hybrid team question where we talk about non-human participants in teams like AI and digital health. And so pretty much every podcast made after 2024 has to talk about AI. And,
Right.
We have a strong interest in the development of new systems that can collect data. And I fully agree that the data needs to be not only actionable to each individual contributor at each level of their care and level of influence, but also accessible across the continuum of care so that we can get a comprehensive perspective of how the patient's physiology is evolving. What role do you see of AI and digital health, particularly in cardiovascular pharmacotherapy? Like
Yeah.
in the
So
world, how can AI help?
yeah, so I definitely look, me personally, and of course, you always have to continue to learn about AI. I mean, it's a vast area and understanding, but I've tried to take the approach of learning about AI as a tool and not being afraid of AI or what could AI do for that. I think obviously being able to assess and analyze data very quickly to help understand, trends or processes to help us make better decisions are always important and key to that whole process. I don't necessarily look at AI as a replacement for what we're trying to do or look at that in the process. And I will tell you the other thing that I always remind people is while AI may be good at doing data and in the current phase, it's not good at being empathetic or having that conversation because even if you have data and want to make a decision, if you're including the patient or the family as a part of those conversations and they should be a part of the team, you have to be able to express what this means and how this is going to impact them or be a part of that shared decision, whether, because maybe the family doesn't want to participate in that risk benefit or something to that effect. So I think that's the key is like data is data and it's helpful and we have to make decisions, but then someone has to be able to express that data to a family or be a part of that conversation piece. And I think that that's still a role that, we're going to have to play as a part of this. It just may help us make, better decisions or be better at having those conversations with the team or the family as a part of this in terms of saying, well, here's what we could do or maybe manage or change differently. And so I think that's where it will help contribute to our understanding of the management of patients. And so I guess to your point, Casey, I look at it more optimistically. But maybe ask me in 20 years and I'll tell you something differently. I don't know.
No,
So
I think you're exactly right. I think humans have to be part of the care delivery. I'm not suggesting AI can replace care delivery, but there are opportunities for AI to tie all the human realms together. So we don't see these patients discreetly. They're not getting sick all at once. They're getting sick slowly. And so if we can use systems that can better understand the progression of disease in ways which are low burden to the patient and easily integrated into the medical decision frameworks that care providers have. And maybe this is a tool that can help.
Well, and
reduce
I look at maybe it's a helpful key to maybe a precision medicine approach, because realistically, like the data that we use today, while we look at the patient as an individual, and I'm not saying I don't look at a patient as an individual, but a lot of the data that is out there that we use to make decision is based on a population data. And so we're sometimes applying population-based data to an individual problem, right? And so you how can you tweak or adjust your solution to more suit that individual? And I think that's the trick.
I think that's especially the case actually in perfusion changes, where we don't know what a person's normal perfusion is. And so they come into the hospital deranged, but we don't know what their normal range is and how to get them back. And so there's a lot of uncertainty, and it sounds sort of like sometimes guessing and checking. This is too low. Oh, this is too high. And then having tools to guide that might be great.
Right. And to your point, everybody's thresholds might be slightly different. But go ahead. Sorry, Dan.
Yeah. So so I appreciate you spending some time with us. There's obviously more for us to learn. We'll never stop learning, not just us, but everyone in this space. We're certainly learning a lot from you, and we appreciate your impact on Envello and your friendship, and for taking time out of your busy schedule today to be with us. So
No,
thanks a
happy
lot,
to.
Craig.
Thank you.
Thanks
Thank you
very
for
much.
having me.